My name is James Lee. I'm the Chief of Endocrine Surgery at Columbia University. I'm also the co-director of the Adrenal Center at Columbia University. I'm what's known as an endocrine surgeon, so I take care of patients with thyroid, parathyroid, and adrenal disease. And adrenal disease has always fascinated me. I think that it is one of the more challenging areas that we deal with. When we're medical students, we learn a lot about specific adrenal diseases because they tend to be quite rare, but quite fascinating in their presentation. And oftentimes, these are the diseases that an astute clinician can diagnose just by listening carefully to a patient, doing a good physical exam. So I've always been fascinated by them, especially pheochromocytoma and paraganglioma. So pheochromocytoma and paraganglioma are, in essence, catecholamine producing tumors. And so catecholamines are the hormones that mediate the fight or flight response. And so the most commonly known catecholamine is adrenaline. So when you are in a situation where you either need to fight your way out or need to run away, your body produces a lot of adrenaline. And so pheos and paragangliomas essentially are in that genre of tumor. So the great divide is that pheochromocytomas are adrenaline-producing tumors or catecholamine-producing tumors that are found in the adrenal glands, and those are glands that sit on top of the kidney towards your back. And paragangliomas are catecholamine-producing tumors that are found anywhere outside of the adrenal glands. So the question of what percentage of these tumors are inherited or genetically linked is a really great question. When I was a younger man, way back in medical school, we would always call the pheos the 10% tumors. So 10% are malignant, 10% bilateral, 10% genetically linked or inherited tumors. What we know now is that there's a much higher rate of having an inherited form of pheo or paraganglioma, and that rate varies depending on who you talk to and what study you look at. But perhaps 30 to 40% of these are somehow inherited. But what we're finding out with each passing year is that we're discovering more and more different mutations in different genes, and that's increasing that rate of inherited tumors significantly. So the short answer is that number is in evolution, and every year we learn more about it. So the percentage of patients with pheos and paragangliomas and an SDHB mutation that have malignant disease is a difficult question to answer. The short answer that people give typically is anywhere from 25 to 40% of patients with an SDHB mutation will have malignant disease. But what we know is that that's really only among the patients that we have studied so far. So these are the patients that we know have an SDHB mutation. We've treated them, we've followed them, and so what we really don't know is the complete data set. So there are lots of patients who have had pheos or paragangliomas, and we don't know whether or not they had SDHB mutations. So knowing what the complete data set looks like, I think will help us answer that question more completely. So I think the best treatment option, initially at least, for pheos and paragangliomas is surgery. So if someone has a surgically amenable tumor, by far the preference is to try and remove it. We say that the best, perhaps the only way of curing someone with these tumors is to remove them surgically. And that actually extends to patients who have disease that aren't completely removable. So debulking is a technique that we use to remove as much of the tumor as we can, and that debulking serves a number of different functions. Oftentimes it gives the patients symptomatic relief, so you decrease the amount of tissue that's creating catecholamines that is causing all the symptoms that are associated with the disease. But it's also debulking the tumor to the extent where there's less tumor to cause problem, there's less tumor that future therapies like chemotherapy, ablative therapy needs to act on. So debulking therapy is a practice that we employ when someone has a tumor that either there's so much burden of disease that it's impossible to remove everything. Patients may have very small disease where we might not be able to identify all of the sites, and sometimes patients will have tumors that are growing into critical structures, big blood vessels, other organs. And so in those scenarios, the idea behind debulking therapy is to remove as much of that tumor as possible. And sometimes, most often when you're debulking, you leave little rims of tissue in major organs or major blood supply that you just can't physically resect in a safe fashion. Pheochromocytoma paraganglioma is one of those diseases where strategy matters, and so pheos and paragangliomas are very, very rare diseases. 1 in 2-3 million patients will actually have one of these tumors. Because it's such a rare disease, a lot of practitioners, probably the majority of practitioners, have never seen one in their careers. Paraganglioma can be found anywhere in the body, anywhere from the skull base all the way down to the bladder. They typically parallel the arterial supply of the body, so wherever there's a big blood vessel, that's where you may find a paraganglioma. Because paragangliomas are so far-ranging in the body, this really requires a multidisciplinary approach. So perhaps the most important thing for treatment for paraganglioma in particular is to go to a center of excellence where they have a multidisciplinary team that is very experienced in taking care of these types of tumors. Where you get treated certainly matters for this type of disease. When you're planning your operative therapy, just because you have an endocrine surgeon on the team is probably not adequate. These tumors are found, again, all over the body, sometimes in the bladder, sometimes by the liver. So you need a variety of specialists who can tackle any tumor in any location. So frequently at our institution, we work very closely with our urologists, with our hepatobiliary surgeons, our thoracic surgeons, sometimes even our head and neck surgeons to adequately remove and safely remove these tumors. Aside from surgery, you need a truly multidisciplinary team. You need superb oncologists, you need superb endocrinologists who are going to take care of the symptomatic disease and the follow-up. You need great radiologists and nuclear medicine specialists. And in addition, you have to treat the entire patient. So you need patient counselors, you need geneticists. So you need really the full spectrum of professionals who are really well-versed in this disease. Pheochromocytomas and paragangliomas release lots of catecholamines into the system typically, and those catecholamines do lots of different things. So raises your heart rate, raises your blood pressure, can cause anxiety and other symptoms. And so those increases in blood pressure, heart rate, cardiovascular manifestations are potentially lethal problems. And so as soon as you're diagnosed with a pheochromocytoma paraganglioma, typically what we'll do is put you on a medication that will help block some of those effects of the catecholamines. The classic medication that we use is a medication called phenoxybenzamine. It's an alpha blocker, and the alpha blocker basically blocks the effect of the catecholamine on blood vessels, on your heart, etc. And so once you're safely alpha blocked, the effects of pheoparaganglioma become less immediately life-threatening. Many of our therapies, because they're blocking sort of the natural response to catecholamines, can have some side effects. So typically with alpha blockade, you get a very stuffy nose. Sometimes you get a little orthostatic, which means if you stand up too quickly, you get a little dizzy, lightheaded. In many ways, that's how you know it's working. If you get a stuffy nose and you start to feel kind of a little bit tired, run down, and we don't like to keep you on it for very long if we can avoid it. During that time where we're giving you the alpha blockers, we typically ask you to drink plenty of fluid and take a little extra salt in the diet. The reason we do that is because as we call it alpha blockade in your system, your blood vessels actually dilate. So the constriction of your blood vessels that the catecholamines cause starts to relax. And as you relax, you need to refill the tank. You need to increase your blood volume again, and that extra fluid helps you with that. During the operation, even in a patient who's adequately prepared with alpha blockade, during the operation you can actually have very wide blood pressure or heart rate swings. And so it's critically important to have an experienced anesthesia team, a group that's seen this disease, have taken care of patients in the operating room multiple times. The anesthesiologists are the ones who really watch over you as we do our operations, and so it's critical that they are also very experienced in this disease. Seeking out centers of excellence for this disease is critical. It's probably the most critical decision you'll make during your evaluation period. Going to a center of excellence ensures that you will have experts in any discipline that you may need. Again, geneticists, oncologists, endocrinologists, surgeons, urologists, radiologists. The reason that's important is because this disease affects your entire body, and so you may find a surgeon who can technically remove this tumor, but they may not know the adequate workup to look for disease elsewhere in the body. They may not have the expertise to prepare you for the operation from a hemodynamic standpoint. So I think finding a multidisciplinary center is probably the most critical decision in seeking care for this disease. There are a handful of centers of excellence across the country, across the world, and by handful, probably 5 or less, that have really decided to focus on this disease and put together the necessary resources. Radiology is a critical component in this disease, primarily in the diagnostics, the localization of tumors, but also potentially in the therapy for tumors. So we always partner with our nuclear medicine specialists as well as our cross-sectional imaging specialists. When we're imaging patients for PHEOs and paragangliomas, we're looking for tumors that are all over the body or potentially all over the body. So using different modalities like PET scans, CT, MRI is critical, and having experts who have seen a lot of these tumors and know where they can hide is particularly important. In addition, one of the additional therapies that we use for patients, especially with metastatic paragangliomas, pheochromocytomas, is ablative MIBG therapy. And that's something that our nuclear medicine specialists team with us on to deliver. The surgical approach to these tumors really is an individualized approach. There are tumors that we can remove laparoscopically quite easily. There are tumors that really require an open resection. There's a lot of talk about whether robotic surgery is helpful or not, but it really ends up being a very individualized decision. So you have to figure out who the individual is, where their tumors are, and whether it's safe to take it out through a minimally invasive approach laparoscopically. Occasionally you'll find a 10-centimeter tumor that looks like you'd be crazy to take out through a minimally invasive approach. But if it's a solitary lesion, we can remove those laparoscopically in a very straightforward fashion if it's in the right place. Conversely, if you may see a 2-centimeter tumor that's sitting right on top of the aorta, which is the biggest blood vessel in the body, and that's probably a tumor you don't want to approach laparoscopically just because the risk of bleeding can be quite catastrophic. And so those you may attack through an open approach. So again, I think it's a very individualized decision that has to be made, and that's why you need to go to a group that has expertise with this type of surgery. When I talk to patients about the operation, the most important thing we talk about certainly is, how we're going to approach the operation. We're going to talk about the expertise of our anesthesiologists, the multidisciplinary team that we'll bring to bear on the case. So if we need a vascular surgeon or a urologist, we'll have them there, and they'll be world's experts. And we talk about the different risks of the procedure and the main benefits. But probably the most important thing we talk about is actually what happens after the operation. And so the most important thing is that our multidisciplinary team is going to follow you very closely. Our endocrinologists will be primarily in charge of surveillance and making sure that from a symptomatic standpoint you're doing well. We'll introduce you to our medical oncologists, and hopefully you'll never have to see their faces again, but if you do, here is the expert that's going to take care of you. But more importantly, I think it's conveying the sense, the understanding that we're in this together. You're now part of our family, and this tends to be a disease that you live with for a long, long time. And hopefully you're going to get sick of seeing us because, we're all in it together, and we'll always be there for you. So I think that's the most important message to convey.